Good morning. I'm Professor Streb, and today we'll be going over your NUR265 Unit 9 content. This is a content enrichment specialist session just to give you some different insight onto what you've been going over. We'll start with Chapter 17. Your syllabus says it will do Chapter 17, 18, 27, 32, 53, 62, and 63. And we're dealing with the immune disorders. So we'll just start with chapter 17 and kind of go down that direction. It might seem like we're going over the places different ways because we truly are. The way this unit is set up, it's kind of tough. It's kind of tough to get everything scrubbed in there. So we'll just keep it light and go from there. Chapter 17 says we need to go to pages 322 to 342, which is pretty much this chapter. So we'll kind of pop in there. What I want you to kind of be cognizant of initially is that this chapter prioritizes the concept of immunity. So everything we're talking about is immune compromise. Immunity concept in this chapter is going with HIV infection, which is a virus that can turn into the disease, which is AIDS. All right, gas exchange, tissue integrity, infection, nutrition, pain are all kind of interrelated concepts. So what is immunity? Immunity is merely the resistance of infection that's associated with the presence of antibodies or cells that act on specific microorganisms. So that's what your immunity is. When you're exposed to some kind of microorganism, your body builds its own resistance. It goes out there and it has antibodies that go in that form against these specific antigens, and it fights it off. Unfortunately, with our bodies, sometimes it can have environmental factors. It can be food. It can be genetics that causes your body to have an overreaction to otherwise normal occurrences. That can be part of our immunity, or in the case of HIV and COVID and a lot of other things, Epstein-Barr, the human papillomavirus, we know that those cause cellular changes across our DNA or our RNA, depending on the type of virus that we're subjected to. So when we think about the HIV infection and AIDS, we know that the human immunodeficient virus is caused by the infection, is an infection that causes the disease, AIDS, the acquired immunodeficiency syndrome, right? So we're going to kind of look at all these together. But we're just saying when you get to like HIV, this stage, when we start going in the different stages, so there's stage 1, there's stage 2, there's stage 3, stage 2, stage 3 starts to progress, and that's known as AIDS. So you can go back in your book and look at that. But in this stage of AIDS, or HIV 3, the third step there, we call that AIDS, is characterized by that profound reduction of immunity. What does that mean? It means that your body is no longer able to protect itself against any kind of opportunistic type infections. So you have increased risk for cancer, for other types of, like I said, opportunistic diseases that will come your way. So a lot of people with AIDS end up dying of other things like, pneumonia or cancer or something along those lines. So having that knowledge in your mind lets you know that a lot of the stuff we're going to worry about with people who have HIV and AIDS is preventing further infection. So that's really what we're trying to do here. All right. With HIV, it's a retrovirus, which is a little bit different. It uses your RNA for the genetic material instead of the DNA. So what that means is the virus tells your RNA in the human cells of the DNA, hey, this enzyme reverses the transcript and it takes control of that cell. And then the RNA for those cells start working for the HIV virus, and it causes further infections. So it's kind of crazy. The HIV virus enters your bloodstream. It hijacks certain parts of your body, certain cells. In this case, it's your CD4 and your T cells. So you'll hear us talk about HIV and CD4 and T cells quite a bit. Why? Because that's the part, or that's the cell, the certain cell that HIV adheres to. So we're going to see a lot of CD4 and T cell talk when we think about HIV and AIDS, because it really kind of gives us an idea of where you're at. All right. For your body to enter the cell, both the GP120 and GP41 must bind to the receptor. What I'm trying to say is, if you go back and read this, that When an adult is infected with HIV, the virus randomly pops into different cells, right? These docking proteins on the outside of your virus, I'll show you a picture down here, you can look at it. They start trying to find the right receptors. So they're opportunistic too. The disease just goes in and bumps around until it finds a receptor it can adhere to. And when it does, when it finds the GP120 bind and it binds to that, to the CD4 receptor, that changes the shape and it allows this 120 to bind either with another co-receptor or this co-receptor. That is how we get this viral binding to the CD4 receptor, and either the co-receptor is needed to enter the cell, right? And it works. We know that when you have that infusion, that fusion inhibitors, they work to prevent the interaction needed for the entry of HIV into the CD4 or the T cells. So when we start looking at this, we look at this class of drug known as a CCR5 antagonist, which works to disrupt these interactions. So we have drugs that can literally prevent the HIV virus, right, from connecting on the CD4, these T cells. So drug class, the fusion inhibitors, drugs known as CCR5 antagonists. These are what we're trying to use and what we do use successfully to prevent HIV. This is why if you get a needle stick, if you have sex with unprotected sex with somebody who might be high risk, you're at high risk now. We would come and take some of these antiviral drugs to prevent the binding and prevent you from getting HIV. It's so cool when you think of it that way. So we kind of go through this. We know that HIV uses the enzyme HIV integrase to get its DNA into the nucleus of the host CD4 T cell, right? It inserts into the host DNA. This action completes the infection, and now you have HIV. It's not necessarily important for your exam, but I really want you to understand how you get infected with HIV. So even if you do something ignorant and you go out and use IV drugs behind somebody, or you have sex unprotected with somebody, don't wait. There are things that we can do. We have to understand this so we can teach our patients what we're here to do. All right, like I said, I'm not going over everything, but I want you to understand when the patient's CD4 count gets low, nurses must prevent infection through reverse isolation, right? Airborne precautions. Think about signs and symptoms of respiratory infection as they are prone to all of these communicable diseases. These are opportunistic diseases that are going to go in and mess up your HIV patient, right? Your patient with HIVs. So we know that the HIV infection, new genetic instructions that now direct your CD4 T cells to become HIV factories, and they make billions of new particles daily. So in this sense, your immune system is made weaker by changing the actions of the T cells. So they're no longer monitoring infections. They're no longer trying to fight infections. Now, what are they doing? They are making the infection. So like I said, that overwhelms the immune system's capacity to make more T cells. And then gradually the CD4 plus, the T cell count falls, your viral numbers, your viral load starts to rise. So now we can start looking at your viral load. And without any kind of treatment, you will end up with some kind of opportunistic infection or cancer. This is what we know about patients who have HIV infection, is that their bodies will continue to make this viral load. Those numbers will continue to rise and their CD4 T cell count will continue to lower. That makes them at increased risk for infection. That is pretty much what we are going to focus on as nurses. So we know that everyone who has AIDS has HIV infection. However, if you have HIV, it does not mean you have to have AIDS. We know that there are plenty of people right now, currently today, who have the HIV infection, right? But we also know that when we keep their numbers low enough, they're no longer problematic. They're no longer going to take that disease and spread it. It's not problematic where it's creating more replication, and the people who have the HIV infection, who have a decreased viral load and have increased T cell load, you know, the ability to fight off infections, they are no longer who we're worried about. So a healthy adult usually has at least 800 to 1,000 CD4 cells, right? And we know that when you get HIV, that number is reduced. So here's what we're looking for. Most adults, when you have an acute infection reaction within 4 weeks of being infected, so within the month, that's typically what happens. So you get symptoms of acute HIV infection, fever, sore throat, rashes, night sweats, chills, headaches, muscle aches, anything that looks like a viral infection. If you've ever had a patient who has a cold sore, fever blister, herpes simplex, herpes type 2 genital herpes, those patients complain constantly of having fatigue because a viral infection causes fatigue. So it's important for you to understand what signs and symptoms look for. I'll let you go back and read all the patients and their classifications and where they're at, but you can start seeing that their CD4 T cell count starts to diminish. And that's when it becomes very problematic. Any patient, regardless of CD4, who has a certain thing, we know they're going to be very subjected to other immunological type issues. And so we know that a poor CD4 T cell function leads to immunity abnormalities. So we have to watch out for leukopenia, meaning there's not enough white blood cell count. If we don't have a high enough white blood cell count, we become more like susceptible to diseases. Think like that neutropenic type patient who doesn't have an immune system. Lymphocytopenia, decreased number of lymphocytes. We know that lymphocytes help destroy things in our body and move them out of the body. Incomplete and non-functional antibodies, abnormally functioning macrophage, so they don't go in there and eat the dead cells like they should. All of these things put your patient at risk for bacterial, fungal, and viral infections and any type of opportunistic cancer. Y'all, this is why our patients, we have to be paying attention to them. We have to see what's going on. One of the biggest opportunities we see with these patients is that flora starts to go unchecked on your body. So candidiasis, albigenous, candidiasis, we start thinking about fungal infections, right? So this is talking about oral or vaginal flora starts to overproliferate, right? Because there's no immune system to fight it off. Your normal bacteria that's there to help can no longer do its job. So when the immune system is working well, these organisms are controlled and the amount does not ever become problematic. But when you have an infection, the profoundly reduced immune system, so that lack of CD4 T cells, it starts getting down below 200, right? Now we start seeing this otherwise harmless organism overgrow and cause symptoms, right? It causes infection. How do we know your patient's having that? One of the biggest signs and symptoms we're going to see from patients who have HIV is often they will complain of changes in taste of food, drinks, etc., because now their mouth is full of this fungal infection. They really can't taste anymore. All right. So now that's kind of where we're at. I just really want you to go back and understand what's going on. Look at these NCLEX examination challenges. Which statement by the client with stage 3 disease or AIDS, whose CD4 cell count has increased from 125 to 400, indicates to the nurse that more teaching is needed. We know if your CD4 count starts to rise, that's a good thing, right? We can go back up here and look. The higher your CD4 T cell counts are, the better off you are. But now my viral load is also probably lower, maybe, as your CD4 starts to go up, your T cells start to go up and start fighting. I just want you to understand kind of what this looks like. I am so relieved that my drug therapy is working. Also, I still have HIV positive, at least I can no longer have AIDS. So make sure you're able to go back and look at these. Which one of these statements is true? Which one of these needs further teaching? I'll make you go look in the book for that because it's important that you go into the book and actually study. All right. So going along the same basis, going along the same vein, we know that when we get to AIDS, that's the HIV, your third stage there. But as we start going and we start thinking about this, we know that when we look at the data surrounding HIV and AIDS, during the International AIDS Conference, it was strongly suggested that if your viral load is suppressed to undetectable levels, less than 20 copies per ml, consistently for at least 6 months or more, the virus cannot be passed sexually. So you're no longer having an active HIV infection. While yes, you still have the virus, HIV virus won't leave your body, no different than somebody who has a cold sore or COVID or something else. They can stay in your body forever. They can make changes because that's what viruses do. They lay dormant and they come back up. But when we start thinking about this, we know now that we can talk to our patients about teaching and let them know that it's okay to have sex with their partner as long as they're keeping their viral load down, they're getting checked. You can take prophylactic medications to help not pass it on. So people are living very normal lives as opposed to what they were. This is just more a chronic disease that you manage. That's it. All right, here are some of the things to go back and look at. Centers for Disease talks about control and prevention. These are just opportunistic things that we see when you have AIDS, right? So candidiasis, you can get it in your throat, you can get it in your lungs, you can get it in your esophagus. Cervical cancer, very invasive. There's all kinds of stuff going on. Herpes simplex, Kaposi sarcoma, we see those all the time. Lymphoma. So we start seeing different changes in our patients. And then this PJ pneumonia down here. I won't even try to explain it for you, but it's something that we see quite frequently with our patients. And these are the things that end up killing our patients because their immune systems are so low. All right. Incident and prevalence. We know that currently HIV is still disproportionately affecting people of color, right? And adults of color. So we see, however, the perception that HIV disease is only a prominent disease for homosexual white men, that is false. The highest rates of new infection occur among adults of color. Why? When we get down here, we look a little further down, it says among racial and ethnic minorities, particularly among Black and African American Hispanics, is where we're seeing a problem. This is all based on socioeconomics still to date. This country is still socioeconomically separated and segregated across different avenues, and access to healthcare and real information is still not making it to minorities and other people who have socioeconomic hardships in this country based on the way we started. So we have to be realistic about why. When we understand why people are more prone to stuff, we can go back and fix the why. It has nothing to do with the race. It has everything to do with the conditions in the country that lead us to this area. An additional group with an increasing risk is, once again, this should be no surprise, transgender community and transgender women. Why? Because of the way our country is viewing people who are transgender and not being open. There's a lot of hate in this country. And the more we don't interact and accept people in our country and accept the people that live with us, we are nurses. We are empathetic, and we must remain equitable, meaning every single person that you treat, you must believe their worth and that they get equability and they have empathy, and you support them in patient-centered care, and only their wants and their needs and their perceptions matter, not yours. So we'll kind of move on from there. All right. Another thing I want you to be aware is often when female patients have gynecological problems, it's usually a persistent or reoccurrent vaginal candidiasis. That might be the first sign that the patient has HIV disease in a woman. So think about pelvic inflammatory disease, PID, genital herpes, any other kind of sexually transmitted infection, cervical dysplasia, cervical cancer. These are big ticket items that when women go get their PAPs, unfortunately, women are still more likely to contract HIV than a man because of the nature of the way body fluids are disseminated, if you will. If a man's penis has no broken skin, it's not likely that a virus will go up your urethra, but as a man ejaculates into the woman's vagina, into the birth canal, then if there's an infection in the semen, it will be disseminated throughout the woman. So we understand, we should understand as nurses, what we're looking for so we can make sure our patients are treated right away. All right. Speaking of that, HIV is found in your blood, semen, vaginal secretions, breast milk, amniotic fluid, urine, feces, saliva, tears, cerebral spinal fluid, lymph nodes, cervical cells, corneal tissue, brain tissue of infected patients. So a lot of these things, blood and semen, breast milk, things that you actually have to do something for. It's not likely that a passive, shaking hands or sneezing or anything like that's going to cause HIV. It's just very unlikely. But it's important that we understand that there are stuff going on. So contact with tears, saliva, sweat, very low risk of transmission, unless there's blood is present. So we know that's not really what we're worried about, but we're really worried about semen, blood, breast milk, vaginal secretions. Those are the ways. So sexual, you know how they're going. For us, we know that needle sticks. So parenteral, sharing of needles, equipment. If we don't do our sterilization process correctly, we're not getting our temperatures high enough, we're not using the time and the chemicals required to get rid of the blood products, then we could inadvertently pass that along. And then from mother to child through certain body fluids during birth, so through the birth canal, Also, breast milk from an infected mother to a child could cause that. So we need to start teaching to adults and children who are of sexual age. If you are in the age of reproductive years, you should talk to children as well. So teach adults about the transmission routes, and children who are going to have sex. It's okay. Ways to reduce their exposure. I get it. Some parents think it's their right and responsibility. I'm a healthcare provider. If you bring me a patient, patient-centered care goes around the patient. I will listen to the parents, but we have to talk with our patients as well. It's a hard job we have. So we have to stress that HIV is not transmitted by sleeping in the same bed as somebody, by using their toilet. Like, we don't have to hate people. We don't have to discriminate. You know, sharing utensils, towels, linens, toilet facilities, it does not transmit HIV. HIV is not spread by mosquitoes or other insects. That's something that they've done research on. So we have to be the smartest people in the room so we can go ahead and fight ignorance. All right, all sexually active adults who know their HIV status is somebody we need to start talking about. So we start looking through here at HIV status. Everybody, all sexually active adults should know their HIV status. You, me, everybody. If you're not in a 100% committed relationship and you know there's been other partners or anything else, it's your job to ensure that your HIV status is up to date. I'll get mine done like I do annually. When I was in the military, it was an every year thing. We had to get it done. I highly recommend people getting their annual HIV exam just to make sure that you don't have HIV. You never know. It's always important not to spread the disease when possible. All right. Here's another thing: instruct couples to use condoms, regardless of whether intercourse is vaginal or anal or even oral, because we know male to female sex is something we talk about all the time, but male to male sex, female to female sex, these are just things we have to talk about. We have to get comfortable talking about sexual intercourse. It's absolutely okay to talk about because we all have sex and we reproduce. It's what the human body does, and it's absolutely okay. All right, viral load is something you should probably go back and check out and read some more on. It's the amount of virus present in the blood and other body fluids, and this affects transmission. The higher the blood level of detectable HIV, the greater risk of sexual or perinatal transmission. So from either sexual intercourse or from mother to child through breast milk or through vaginal birth or something of that nature. You already know what you're supposed to do. Safe sex, latex condoms, use water-based lubricants to reduce. You want to reduce friction. The better you are at reducing skin breakdown and allowing blood to mix in with vaginal secretions and semen, you're far less likely to get the transmission of HIV. This is why anal sex can be more problematic, especially if you're not using the right kind of water-based lubricant, because you can get tears and rips in the skin of the penis and the rectum. So that's what we're talking about. All right, pre-exposure prophylaxis, PrEP. We're talking about a medication that we can give, and you can go back and look at different names, right? Because there are different names on it. I'm getting into them because I don't know what NCLEX is going to ask you. These are just things that we need you to kind of start thinking about, right? There are certain drugs that we give pre-exposure. They do have black box warnings, right? So if you're infected with hepatitis B virus, it could cause you to have an exacerbation of hepatitis B, and it can cause some liver issues. So why would somebody take this? Well, this is for people who are high risk for acquiring HIV. If you are somebody who has you're non-monogamous and you have heterosexual activity with men or women, or you have homosexual sex with men and women, if you're out there in a non-monogamous relationship and you are having sex with people, you might want to be on this pre-exposure. Is it bad for your liver? Yeah, it can be. But is HIV worse? Absolutely. So this is just to be smart. If you do drugs, if you're an IV drug user, if you're in a relationship with some partner who has HIV, or one partner is HIV negative, you will want to be on these pre-exposure medications. And they have an amazing track record of preventing you from contracting the disease. Like I said, but the person using the PrEP is not protected until day 7, consistent with dosing allows for a steady blood, right? So you have to at least take it for 7 days prior to having intercourse unprotected. You should probably have unprotected sex anyway, But if you're not, right, here we go. So we know that PrEP doesn't replace the standard safer sex practices, right? By using condoms, by doing this stuff, but it's something that we need to be aware of. Post exposure can be for a lot of stuff. So when you start thinking about your cart down here, we call that heart for a while. Now we call it cart. Just in case you see those words, don't be confused. What we're talking about here is a patient who has been exposed to something. So you had consensual sex exposure. You could have got stuck by a needle. It could have been anything along those natures. What we know is consensual sex exposed with a person of unknown HIV status. So you have sex with somebody, you have a one-night stand, your person's like, look, I don't know if I have AIDS or not. I don't know if I have HIV. I've never been tested. It's probably a good idea to go in and start this. Once again, you get sharks, you get hit by a needle. Are you probably going to get HIV if you get stuck by an insulin needle? Probably not. If it's a large bore 18 gauge IV needle, very much more likely, because now you think about the bore size and the ability of blood to get into your system and go there. So current recommendations indicate that significant exposure be treated with the same 3-drug regimen of CART for 28 days or until the HIV status of the source has been determined to be negative. So there are medications. Go back and think about what we're doing here. I want you to know that if you do get stuck in clinical or as a nurse, there are things that we have to do to get you out there. And we need to get it done quickly though. So we want to get this exposure. Once you get exposed, you want to get in there quick, right? So the 3-drug CART needs to be started once the exposure occurs. Within 2 hours of exposure has the best outcome of preventing HIV infection. This is why we're so adamant that, like, if you're doing something and you rip your glove and you're like, I don't know if that's my blood or somebody else's blood, it doesn't matter. Just start the CART treatment, right? Best outcome decreases when the prophylaxis is started 36 hours later. So if you have a one-night stand, or you get stuck, or you're just not sure if your partner is as truthful as they say they are, it's probably important. Don't wait around. We know that anything we do quicker, we have a far better chance of not screwing it up, right? Or catching the disease or whatever going on. So like I said, you can go back and read some of these. There's a lot of great information that I want you to go back and think about the parental transmissions versus the perinatal, just things you can go back and check on. All right. To prevent HIV transmission to patients, healthcare workers must wear gloves when they contact a patient's mucous membranes or non-intact skin. So if you put your hand in somebody's mouth or anywhere else where they have mucous membranes, you can kind of get where I'm going here, you should wear a glove. And this is a bad joke, but no glove, no love. This is always the same. You should not touch a patient anywhere where you have the risk of transmitting body fluids. That should be the same with a person that you're having intercourse with, unless you are adamantly sure. And are we ever 100% sure? I don't know. You got to use your best judgment. But if it's non-intact skin, there's a cut, there's a break in the skin, you should be wearing gloves. This is a no-brainer, but a lot of times we don't think about it. All right, key features with treatment with HIV with diseases at stage 2. Chronic infection, as it gets higher and higher, we need more and more interaction with interprofessional teams. Here are some things to be looking out for. When somebody has AIDS, look for those low white blood counts. Think about the CD4, the ratio, how it's off. Think about this right here, your CD4 count less than 200. These are problematic. Dry skin, poor wound healing, night sweats. These are integumentary system issues that we see change. Cough, shortness of breath, we start thinking about pneumonia. Diarrhea, weight loss, there's all kinds of GI problems because of that lack of good flora, and the good bacteria in your body that's naturally in your gut is no longer there. So we're not able to absorb food like we should, and it causes diarrhea, weight loss, things of that nature. A lot of the stuff looks very, very much like anything else, headaches, fever, we don't always know. All kinds of different types of protozoal type infections. So we think about, your candidiasis down here on the fungal infections. That is a big one. I always say the PJ pneumonia. Like I said, I'll never try to pronounce it because it's just too difficult for most people. But there are things that just keep popping up that we as nurses should be aware of. Because if we're not aware that they exist, how do we know we're supposed to watch out for them? All right. It's important. It's important to get a history, y'all. So much. So recognize clues. Adults who have HIV disease, they need to be monitored regularly for immunity changes, for health status changes, every 2 to 6 months, just to make sure they're staying on top of their game. We need to think about age, gender, occupation, where people live, where they're at, what their lifestyles are, how the are they getting transfusions? All this matters. If you were born at a certain time frame, we gave blood transfusions to people. We weren't checking for HIV and hepatitis. Certain genders, once again, you're at greater risk. Occupations, if you're a healthcare worker, you're at greater risk for these type of stuff. If you're a sex worker, right? If you do pornography, things like that, where you might have multiple partners. Nothing wrong with that if that's your choice, but understanding the importance of knowing what you're exposed to. That's what we're talking about. So ask the patient about sex practices, their STIs, their infectious diseases, tuberculosis, hepatitis. Patients with any of these going on have a higher risk. If a patient has hemophilia, ask about, did they get clotting factors? Ask whether they engaged in any kind of injection type drugs. Did they get a lot of blood transfusion? That puts them at risk for HIV and AIDS. These opportunistic infections are something I want you to really focus on, because they are caused by an overgrowth of the microbiome, the normal floras. So we have to think about that. We know that temporary reduction of immunity can result in death if treatment is not started quickly. So we have to pay attention when we see opportunistic infections. Go down here to your PCP, right? Pneumocystis, J, pneumonia. Look for shortness of breath. Look for tachypnea. Look for that persistent dry cough. Why do they have a dry cough? Why do they have this low-grade fever? Why are they fatigued? Why do they have weight loss? Why do they have crackles? It's an opportunistic infection. So when you think about patients with HIV and AIDS, we're not trying to fix them. We're not. There are drugs that work and there are drugs that may not work. Great, we'll try those. We're looking for opportunistic infections that are going to kill our patient, right? That's what we're looking at. So offer high protein calorie foods, drink 2 to 3 liters of water daily. Auscultate breath sounds often. These are the things we do when patient has signs and symptoms of some kind of fungal infection or protozoa type infection. Look for that candidias, right? Ask the patients about their food tasting. Does it taste funny? Is it weird? Do you have difficulty swallowing? Do you have pain in your throat or your chest when you eat? These are signs and symptoms that your patient might have an opportunistic type infection. Esophagitis, stomatitis, right? All of these things can change the way your patient swallows, eats, drinks, tastes. So it's going to be important that you're asking questions. Think about vaginal itching, because vaginal discharge could cause toperitis, which is itching, perineal irritation. These things are what we are going to focus on and try to figure out exactly what it is we're looking at so we can determine what's going on with our patients. All right. All right, kind of stay on this last part here. Tuberculosis is another infection. It's caused by, TB. We know that. It doesn't occur very often, but we know as your immune system goes down, more than 50% of all patients at the HIV-3 level, so we're talking about AIDS, who also have TB, it's crazy, right? So we have to ask about coughs. We have to ask about dyspnea and chest pain and fever and chills and night sweats and weight loss and anorexia. We have to ask about these. It could be tuberculosis, right? The adult who has TB and a CD4 count below 200 may not show that they are positive for TB when you do the PPD, because they don't have the ability to mount an immune response. So these patients, when they come into your hospital and they have a history of HIV or AIDS, and they start having certain signs and symptoms, it's super important that we start thinking, TB, PPD might not work. So we have to send them off and get some kind of test and make sure that we're getting blood type tests first, right? So place this patient on airborne precautions immediately. Don't wait to see if they have TB, just assume they do. So maintain airborne precautions for any patient who has TB symptoms until parameters other than a skin test come back to let us know. We know that. These are the type of things that NCLEX is always going to ask you. So if this makes sense to you, go back and look at everything. Make sure you're really looking at what's going to kill other patients, what is really going to put your patient at the greatest risk. We know that any kind of infection, whether it be herpes, whether it be another viral infection, varicella, another herpes zoster, right? That's what chickenpox is. Y'all, viruses cause viruses. We have malignancies. We know that weakened immune systems increase your risk for cancer. We already know that. Kaposi sarcoma, lipomas, cervical cancer, lung cancer, GI cancer, anal cancer, all of these you're more at risk for. So we have to be on the lookout for them so we can try to intervene immediately and slow down that disease process. All right, so that's where a lot of your HIV is. We're going to keep going down a little bit more. You can keep reading that. But here's what I want you to do. Avoid crowds and other large gatherings. Bathe daily. Use antimicrobial soap. Avoid eating undercooked meats, fishes, and eggs. Don't change pet litter. Take your temperature at least once a day. And whenever you do not feel well, you should take your temperature. Consult your primary health care provider immediately if you have temperatures over 100. Take all your prescribed medications. Make sure medications should be taken correctly at least 90% of the time. Make sure you teach these patients that, and you'll see a lot better outcome. All right, then we're going to stop on that. That's what we did for HIV, and we'll talk more later. Thank you.